probably we have to think differently. As you heard this morning, many of these techniques that we've been talking about actually work in the right patient. So the question is not whether LTT is the standard, the question is when is it that this operation is best? And for me, the indications include a patient with an irreparable posterior superior calf tear, where the patient has no arthritis and substantial fatty infiltration, unlike my previous speaker. And the main reason for surgery is loss of active standard rotation with possible involvement of the teres minor in a patient that has no escape. So look at this case presentation of a patient that is in his mid-50s. There is some migration proximally, but the osteoarticular cartilage is well preserved, and there is advanced fatty infiltration of the supra and the infra. This actually doesn't tell you the whole picture, because if you now examine this patient, you will see that he has isolated loss of active standard rotation. So I think for this particular patient, nothing is going to work, including a reverse, no SCR, no tuberoplasty. This patient needs, like Dr. Tokis mentioned, a live muscle, and like Dr. Warner demonstrated yesterday. So yesterday we had a great demonstration by Eric Wagner from Emory. There were about 50 people here, but not everyone. So the way we do the operation is the harvest is done open, and then the fixation of the intercalary graft, in our case we use an Achilles tendon allograft, is done arthroscopically and always associated with repair of whatever calf can be repaired. The part that most surgeons want to learn about is how you do the harvest, and you can do this in the lateral. My preference is to use the V-chair position, and it's important when you position the patient to drape so that you can reach